Welcome to Take the Lead Radio with Dr. Diane Hamilton, where she interviews some of the most successful leaders, entrepreneurs, authors, speakers, and other individuals who will inspire you to take the lead in your career and personal life. And now, here is Dr. Diane Hamilton.
I am here with Dr. Warrick Bishop, who is a practicing cardiologist, #1 international best-selling author, and keynote speaker who has a passion to help prevent heart disease on a global scale. He is the author, Have You Planned Your Heart Attack? I love the name of the book. And I just am very anxious to talk to you about this. Welcome, Dr. Bishop.
Well, thank you for having me, Diane, and thanks for making the time to allow me to join you from the other side of the world, in actual fact.
Oh, that's right. I get a few people from Australia on the show, and you're one of the early risers. I liked it because usually sometimes they make me do them late in the afternoon. I'm getting tired by that time, but this worked out. It's
perfect. I think I'm a day ahead and in the morning, so we'll be just fine.
Well, you have quite an impressive background. I was looking at all your memberships and certifications and boards you're on and different things that you do. And I could see why you would be an expert in, all the issues that you write about. I have a family that's, got terrible history of hypercholesterolemia and whatever else that you probably wrote about in your book. And I'm very interested in heart disease. And my husband and I actually ran for the Stroke Association to raise money and different things, but you've been recognized by the medical school of the University of Tasmania with academic status, and you've really got quite a background in the cardiac realm. So this is going to be really interesting to me since I sold cardiac meds, and you're talking about a lot of things that my husband and I talk about in terms of misinformation. Even by doctors don't really have a real good idea of what's good and what's not good for the heart, and they're kind of going off the old information. So let's just start with your background. Before we get into that, tell me a little bit about you, where you're from, and how you got to be this cardiologist that's so specialized.
Well, I really appreciate the introduction. The truth be told, you've sort of described me as someone far smarter than the person sitting here talking to you at the moment. The reality is that I was a fairly average, mediocre general cardiologist. And in fact, I had something happen a couple of years ago, which really changed my direction. And that change in direction really forced a whole heap of changes, a whole heap of focus, and really actually drove me to join these boards, do more in the research space, to be engaged in preventative issues. But my background, and I'll come back to why that was, but my background is I pretty well grew up here in Tasmania, which is the island south of Australia. I did a lot of my training here in Australia and around Australia, and really focused on adult medicine, which was clinic-based. So did blood pressure and chest pains and funny heartbeats and looked after heart attacks and all the standard sort of stuff.
Well, I'm curious, in Australia, did they say it angina or angina? I still can't get it right here.
No, we say angina.
Okay, all right. I just wanted to make sure if we had that.
Angina. We draw it out a little bit.
Well, if for those who aren't familiar, that's chest pain, basically, from ischemia, lack of oxygen, right, to the heart?
Exactly.
Okay.
Exactly.
All right. So I actually have kind of a master's. They didn't call it that, but it's a certification training that's a couple of years graduate level, that as a certified medical rep when I was a pharmaceutical rep. So I had to take a lot of anatomy and physiology, and we studied a lot of this stuff. And actually the heart was my main focus since I sold to Norman and Zestrol and a lot of those medications, lisinopril, I guess now, and atenolol now that they're generic. But I think that what I found when I was a pharmaceutical rep was it was very scary to see behind the curtain of what doctors knew and didn't know. And you could kind of just get a little bit like worried about this because they can't know everything. I mean, they're obviously very smart. They got into what they're doing, but there's so many medications. There's so many different ways of looking at the research. And one day it's good to eat carbs, and orange juice will be the best thing, and the next thing, orange juice the worst thing. Where do you stand on carbs now? Is it the inflammation that's going to give us heart disease, or is it okay to eat carbs? What is the right answer to that?
So I'm gonna respond and then sidestep. So get ready. The response is, I think, and this is my own experience, I think we have to be really aware and cognizant of the limitations of our knowledge and how complex individuals and their systems, their biological systems really are. We know so much in medicine, but I think we really run into problems when we start to believe we know it all. So there's no doubt in my mind that knowledge is incredibly important, and we always have to be open to what more we can learn. When it comes to carbs and inflammation, I'll come back to that later if we've got time, but if it's all right with you, I'd love to indulge you with the story that actually set me on a different path, and actually has probably ended up with me speaking with you today, Diane.
Okay.
Well, it was literally a Saturday in May of 2005, and I was driving to work. I had patients to see. At the same time, there was a fun run in progress, and in Australia we do things called fun runs where people all get together and run 5 or 10 kilometres. Apparently it's fun, but people love to do it. And this was called the City to Casino Fun Run, and as it happened, the course was right past, or very close to where my hospital was. So as I went to work, I was running past the field of runners. Well, I noticed there was a commotion in the crowd. There was an ambulance, there were people standing around, and I literally thought, well, I'm a doctor, don't know if I can help, but I'll just stop and see if I can offer some support. Well, it turned out a man, while in this fun run, had literally dropped dead from a heart attack and was being resuscitated by the roadside. He'd had a heart attack and a cardiac arrest. I was involved in that resuscitation with a couple of other bystanders, but of course the paramedics from the ambulance, and that man survived. He did so well that we got him to a local hospital, the nearest hospital. He got stents put in, and because he did so well, he ended up on the front page of the paper a day or two later. Now, I don't want to sound too self-indulgent, but that was a pretty good story, and it was a pretty good thing to be involved with. Right. And so when I got a copy of the paper, perhaps just a little bit proud, I wandered into my office and showed my staff and said, I was there. At which stage, one of my staff, who recognised the name of the patient, said, but Warrick, you saw him about 18 months ago. He's one of yours.
Wow.
So I can't tell you how I began to feel when I realised that a man I'd seen only 18 months earlier had dropped dead during a running race. So I went and looked at his notes. Actually, I went back and looked at his notes. I'd seen him in 2003. He'd come with some non-specific chest pain. I'd done a treadmill test, which at the time was exactly what we should do. Right. He performed really well on that because he'd been keeping himself fit. He had a little bit of blood pressure. We adjusted his medication a little bit, and I suggested he take a little bit of aspirin. And that was it. Yeah. That was it.
Just the typical Diane, care kind of thing where you go through the list, right?
Right. And that was the list that was appropriate at the time.
Right.
And I didn't do anything wrong, but I realized it wasn't right.
Mm-hmm. Yeah.
So the upshot of that was that I really became very aware of any technology that may allow us to be far more precise in assessing risk. I'd done a treadmill test on this guy, and I could tell him he was fit. I could tell him he could exercise for 9.5 or 10 minutes, but I couldn't tell him the health of his arteries, and that's what put him down. That's what allowed him to have a heart attack in the middle of this fun run. So it turned out that literally around that time, more and more technology and more information was coming out around imaging the heart and the way to take pictures of the beating heart inside someone's chest to literally get pictures of the arteries and see what the health of those arteries look like, knowing that some people can look really fit and well on the outside, but can still have a heart attack.
You know, it's so interesting because I've had so many people I know who've had different things, and maybe they go in and they go, "Hey, did you see you had ST segment depression over here?" What, you know, and they have no idea that there's even something wrong with them. Sometimes they don't even have heart pains. Or I have had a guy just like the guy you're talking about was my physical therapist. He dropped dead at 35 after being like in all these marathons and stuff. And he happened to do it at work where they saved him. And now this is like 20 years later, he's got in his heart, you know, the thing that zaps you. What am I trying to think of?
Defibrillator? A defibrillator?
Yeah, defibrillator. So he's got a pacemaker. So, you know, and so he's got, you know, there's so many people that we need to do better imaging to find out what's wrong. But can you pick up things like arrhythmias or different, what can you see with the imaging now?
Yeah, so this imaging is really predominantly and almost specifically about coronary artery disease. And that's sort of okay, because coronary artery disease, separate to arrhythmias and cardiac failure, coronary artery disease is still the single largest killer in our community. And far greater numbers for both men and women. But most importantly, we can do something about it before a problem occurs. We can modify risk and we can alter someone's outcome. And so it's an incredibly valuable piece of information. So my journey was about learning more about this imaging, and I was the first cardiologist in the area that I work in to really do a lot of training in that space. And honestly, Diane, the more I used this, the more I scanned people's hearts, the more I realized that I just couldn't tell what was going on with someone by looking at them from the outside and, you know, checking their cholesterol or blood pressure or how fit they were or what they ate or what their family history was. You know, I had, for example, 2 sisters from the same family, both with high cholesterol. One had terrible arteries,
yeah,
and the other had nothing in their arteries. And I realized that the complexity of the process of coronary artery disease is something we haven't really got our heads around. We understand lots about it, but we don't understand exactly what's driving the process. And it seems different in different people. So if you don't really know, it seems like a good way to find out is just to have a look and then go from there.
Yeah, I'm interested in all the different things that, you know, when I left I worked for AstraZeneca for 20 years, 15 of them in pharmaceuticals. And, you know, when we talked about a lot of the stuff, I think they were just about to sell a lipid lowering drug, Crestor, at the time when I left. And, you know, I know that drug companies want to solve all the problems with medications, and people want to be able to eat whatever they want. So they take these medications and say, well, now I can eat this, you know, double-decker, greasy, whatever it is I want to eat. But you know what, we don't know what we can eat. And then they talk about, you know, this is cholesterol. First, eggs are bad, then they're good. There's good cholesterol, there's bad cholesterol. If you have a good HDL ratio, you're good. You know, I mean, they keep changing it. That I'm like, well, next week it's going to be something different. But it's so hard as an individual to know what we can do. And I think a lot of people listening won't be doctors. So they're going to be people who want to know, well, who do I listen to? Do I ask for this scan? What should I be eating? I mean, what do you tell?
So look, again, if we have time, I'll come back to the eating issues, because they are complicated. Mm-hmm. And I think there is a lot of misinformation out there. But when it comes to the scan, what I was actually energized and focused, and I felt like I actually had a secret that I needed to share with my colleagues and local doctors, family doctors here. And as I spoke with my colleagues, I realized that, you know, change is a really difficult thing. And they were pretty comfortable doing what they'd been doing for years, which is what I'd done for the Fun Runner, which is put people on a treadmill test and reassure them. And I got really frustrated with that. In fact, I felt like a pioneer getting arrows and criticism and, you know, you justify this better than you are and so forth. And so I got very despondent that I couldn't push this technology locally And when I spoke with the family doctors, I realized there was actually a fairly complicated discussion that required more than a quick visit and a couple of main pointers. So that I ended up in a situation, Diane, where I wanted to get a thorough explanation and message out. And that's why I wrote the book. And I called the book, Have You Planned Your Heart Attack? Of course, it sounds a bit tongue in cheek. I don't want people to plan. I want people to plan not to have a heart attack. But that's why I wrote the book. And in fact, that from writing the book, it's actually sent me on the journey where I'm, fortunate enough to have the opportunity to speak with podcast or radio hosts the other side of the world, which is fantastic, actually. So I'm still in the process of trying to raise awareness and give people good information.
Well, so what does the scan consist of when you go in to look for this? Is this something that they're going to inject you with any kind of iodine or dye, or is it more like MRI that they do, or is it CT scan? What exactly would people go through to make sure that you could see what they need to see?
Yeah, so the scan that we use for the heart is the CT scanner. And we've really been able to do that in the last decade or so because the technology is improved. And because the technology is improved, we can now take pictures of the moving heart. Because, of course, the heart beats 60 or 70 times a minute. We needed the technology to be able to freeze the heart while we were imaging it,
right,
so that we could get reproducible and reliable images. And that's now happening. And really the role of this technology is in trying to inform the best management strategies for individuals. So, a good way to think of it is if I took an average 50-year-old male who went to his local doctor and said, what's my risk of a heart attack? The doctor might take his cholesterol, which could be average, his blood pressure, which could be average. He's a non-smoker, non-diabetic. But at the age of 50, a man moves into what we call intermediate risk. And intermediate risk means that there's this is how we say it, there's a 10% chance of a heart attack in the next 10 years. Now, that doesn't sound like a lot. And historically, when we've run one of these risk calculators on a patient, this arbitrary 50-year-old male, historically we'd turn around and say, look, you're not that bad, you don't need treatment, we don't need to put statins in the water, etc., etc. You'll be fine, we'll see you in a couple of years and see how you're going. But I think we need to reframe the way these risk calculators work and then put them in the context of the individual. Because when we use these risk calculators, what we're actually saying is if we take 100 people with the same characteristics that you've got and follow those 100 people for 10 years, we know 10 of them will have an event.
Right. That's
a 10%, that's a 1 in 10 or 10% chance. We just don't know which ones it is. Who is it going to be? And so, say that again.
It'd be nice to know which one.
Well, so enter imaging. We take the 100 men, we put them through a scanner. We find 25% that've got lots of stuff in their arteries. We find 25% have nothing in their arteries, and we find a 50% group in the middle who are the average 50% group in the middle. And now, do you think that could be helpful in directing specific management for those individuals?
Right.
Of course it is. Mm-hmm. Yeah, of course it is.
Mm-hmm. Yeah. And well, I have, what comes to mind, I want to ask you when you're talking about giving these CT scans is what radiation is there involved? How often do you give it? And is that a factor to consider? Is it worth doing?
Look, that's a great question. And in fact, I did cover a lot of the hurdles to change in my book, specifically because things like radiation and cost and the research behind it are all the excuses or all the replies from people who don't want to adopt the technology, who want to continue doing what they're doing. Now, as I've sort of said to you, technology is a changing field, which from, you only need to pick up your phone to recognize technology is changing all the time. When it comes to scanning the heart, 20 odd years ago or 15 odd years ago, when we were really early in our stages of developing this technology, the radiation dose was quite high. And to be honest, probably verging on unacceptable for a broad use within the population. But the most recent iteration of scanners using clever technology to minimize radiation dose really exposed patients to little more than a mammogram dose of radiation.
Mm-hmm.
So we are very comfortable with mammography as a screening tool for a condition that doesn't kill anywhere near as many people as heart attack. And so we can scan the heart with a radiation dose, which is about the same as a mammogram, which makes it incredibly safe and well within the sort of expectation that we'd have.
There's no use of MRI or ultrasound because they're just not able to capture the same thing, right? So
yeah, different modalities look at things slightly differently. The coronary arteries move really quickly, and the differentiation of the tissue is not enough for the ultrasound and too fast for the MR. So CT works really well, and look, that radiation dose is pretty small. And for a 50-year-old bloke or a 60-year-old woman, for argument's sake, it really wouldn't have a significant impact at all, particularly when we think that the flip side is that coronary artery disease kills 50% of the population. So,
well, that's an interesting, that coincidence that I just saw, that Susan Lucci just found out she had heart disease, and who's in better shape than this actress who's like skinny as a rail and eats perfectly. And it's drawing attention right now. So let's say somebody like her or you or me, or anybody who is out there who, let's say we just take good care of ourselves. We've done pretty well, but then we do this scan and we find out, hey, I've got the widowmaker in trouble here. Well, how did this happen? So what's the next step?
Well, look, there isn't a single answer. And I think that's really important to understand. In fact, the whole reason, excuse me, that's my cold. In fact, when I was in Phoenix last year, I was being interviewed by one of the TV hosts, and the interviewer said, Warrick, what's the single thing that you want to get across for people? And I said, look, honestly, if it were a single thing, I would have written a postcard, not a book. And the reality, Diane, is it's complicated. I think we have to recognize that these things are complicated, but the absolute premise of what I think we should be trying to do is operate from a platform of the best information. So if you've got stuff in your arteries, if it's good, bad, or something in between, that needs to be matched up with who you are. Are you overweight, underweight, cholesterol high, family history bad, whatever that may be. And the extent of your holistic assessment needs to be worked through by someone who knows how to deal with this technology. Or if they don't know how to deal with this technology, hopefully I've written a book that someone will access and get an idea of how you bring some of all these issues together to answer the question of the best way forward for an individual.
I know doctors have to go to get their CME credits, their continuing medical education credits, just like real estate agents and different people get their continuing guidelines who are listening to this, or SHRM and different things. Different industries have their credits they have to continually get. So are they talking about this when you go to meetings, and is this something that you're seeing is being adopted by the medical associations and societies to which you're a member?
Absolutely. There is a changing of the tide, no question. And a decade or so ago, I think I said to you I was receiving arrows from my colleagues. Currently, I'm involved with the Heart Foundation here in Australia, and we're looking to write a position policy on imaging the heart. So there's been a tectonic shift in that regard. I'm also involved with the local Society of Cardiac Computer Tomography, and that's the organisation in America, which is the parent organisation, but I'm in one of the local chapters here, and we're looking to start to make inroads into approaching the government here in Australia to make this sort of testing more broadly available for, providing the best information in trying to understand someone's risk into the future. And that's because, like you said, sometimes we see people who look fit and well on the outside, and until you've scanned their heart, you can't tell that there's literally rust in the pipes that may well cause them problems.
Right. I mean, I can remember calling on a doctor who was playing tennis, best shape of all the doctors I called on, and he died playing tennis, and he, had apparently the best information. As a doctor, you would think you guys know the most, right? So it's hard because you think you know what you know at the time, and then somebody uncovers something new. And in our last couple minutes, I know we've teased a little bit about what we could eat, and I know you really want to be focused on this test, which I think we covered, and I think it's really important. But I think so that even when we get to the test, we're going to find good things are there. What suggestions? How bad are carbs for inflammation? And is inflammation the thing that causes all the problems and people don't realize it? Is that possible?
Yeah, so I think there's a lot of noise on social media which can draw conversations in a particular direction. Mm-hmm. My own practice is to suggest to people that they don't do too much in the way of carbs. And I certainly have a group of patients who are brisk insulin responders to carbohydrate exposure. And for that group of people, I really suggest that they try and cut their carbohydrates down as much as possible. They're the people who may have central weight gain, central adiposity, family history of diabetes, elevated triglycerides. That group of people really respond well to reduction of carbohydrate. One of the things about inflammation is it's a complex thing to try and measure, and it's been thrown around a lot in social media particularly, and there are papers suggesting that it may well be important. There was a trial called the Cantos Trial, which was released in the last year, and that trial literally looked at modifying inflammation to try and modify outcome in terms of coronary artery disease, and it did show that inflammation was involved. The trouble was it was only a small amount. It wasn't dramatic. It was statistically significant, but it wasn't dramatic. Now, I think that there's half a chance that carbohydrates, together with the elevation of insulin and some of the other hormones that are associated with raised insulin, may well drive inflammatory changes. But it's a really complicated area. And I think it's important to understand that if we do find someone who's got stuff in their coronary arteries, then what we want to do is address as many of their risks or address as many of the factors we can that we can modify. So inflammation and diet is really important. Exercise is important. Taking your tablets, whether that's aspirin or a cholesterol lowering tablet, is really important. Getting your blood pressure under control, really important. And I think it's from my perspective, I'm always cautious about people suggesting, for example, I'll drive from Phoenix to LA and I promise I'll drive safely, but I won't wear a seatbelt or I'll disconnect the airbag. Because when it comes, this is true, when it comes to coronary disease, it's a bit like driving your car. You want everything on your side in your favor. So you want to have as many airbags as possible. You want to have your seatbelt on. You want good brakes, good tires, and diet fits in with that. But so does good mental health, and so does good physical health, and so does a good doctor who's evaluated your arteries and knows exactly what you're dealing with into the future. So, really important, Diane, but my observation is a lot of people cling on to one aspect, and that's just like saying, it really doesn't give you the safest journey. You want everything stacked in your favor.
Yeah, it's the foods are, it's a tough thing when people are really pretty much addicted to food and the types of foods that they're used to eating. It's a very hard thing for people to give up their favorite things. And I think sometimes they think they'll take a pill and that'll solve that. Then they can do what they want to do. And it's hard, but until you've gone through one of these major cardiac events to know what it could really do to you. You know, sometimes bad things happen to talk people into doing the right thing, unfortunately. So I think it's really great that you're trying to find a solution to a very serious problem. And I think a lot of people, first of all, would love the name of your book, which I did, and but would also like to read your book. Have you planned your heart attack? And how can they get your book? How can they find out more about you?
Well, look, the easiest way to find out about me is just to go to my website, which is www.drwarrick, W-A-R-R-I-C-K, bishop.com. So if you just Google Dr. Warrick Bishop, you'll find me on my website. I've actually got a free TV show, which I put together as a sort of a complement to the book. My book is available on my website. And the book's available through Amazon as well. So it's broadly available. And it's also available as an audio book if that was more convenient.
Yeah, well, I mean, it's a great topic. I think a lot of people really need to know more about this. And a lot of people who listen to this are workaholics and maybe need to take better care of themselves. So I really hope that everybody takes a look at what you're working on. And thank you for being on the show, Dr. Bishop. It was really nice to have you here.
Diane, thank you.
Really enjoyed.
Absolute pleasure talking with you. And maybe when I release my new book in the next couple of months, we might have the chance to do this again.
That would be wonderful. And Dr. Warrick Bishop, thank you. And we'll be back right after this message.